Good evening to all the aspirants present. We are going to start our session. The domain name is Endocrine Disorder, and the speaker that we have here is Dr. Anup Kumar. Sir, you may take over. Thank you.
Good evening, friends. So today in this crash course, we'll be discussing the questions in endocrinology session. So basically, there are a few important domains in endocrinology. So only few of them only we have covered in this one. So after discussing the questions, we'll just go through what are the other important domains also. Coming to the first question, as you can you can see here, hyperglycemia adversely affect outcomes. Mark the true statement out of these things which is true. Like hyperglycemia predisposes to disturbance in sodium, potassium, and phosphate concentrations. Uncontrolled glycemia appears to impair innate immunity. Endothelial functions may also be impaired by hyperglycemia. Hyperglycemia also provokes an osmotic diuresis leading to symptomatic hyponatremia. Hypophosphatemia predisposes to arrhythmias. So we'll see what is the answer options here. So here the first one, this is predisposes to disturbance in sodium, potassium, and phosphate concentration. I think you all will be aware about that, especially potassium and phosphate concentration, all will be aware. You can have sodium variations also because of the fluid shift and osmotic diuresis. Obviously, it will impair immunity, diabetic stage. Endothelial functions may also be impaired. I think there won't be any confusion in that choice as well. The next one is it also provokes an osmotic diuresis leading to symptomatic hyponatremia. Usually, it provokes osmotic diuresis, but hyponatremia may not be that significant. And hypophosphatemia predisposes to arrhythmias. Whether to treat hypophosphatemia in hyperglycemic stage itself is controversial, and it is unlikely to predispose to arrhythmias. So here actually you can see these options which we have already discussed. It can impair the immunity, innate immune response, granulocyte functions, and microorganisms expresses more virulent factors in high glucose environment. Endothelial functions may also be impaired by hyperglycemia. In general, better regulation glucose leads to improvement in parameters. So the only confusion will be regarding hyponatremia. So that part actually you can just read once again. So before going to the next question, you should be well aware about the diagnosis of diabetes and the latest 2025 criteria. So HbA1c should be more than 6.5, or in millimoles, usually it is expressed. In that case, it should be more than 48 millimoles per moles. Fasting sugar more than 126. The 2-hour ppg more than 200. Or in an individual with classic symptoms of hyperglycemia or hyperglycemic crisis, an RBS value of more than 200. So these are the diagnostic criteria. Now, diagnostic criteria for DK and HSS is also very important, especially for these MCQ purpose. The DK diagnostic criteria are diabetes where the glucose values is more than 200 or prior history of diabetes. So this is very important. Even if the sugar is normal, if you have a prior history of diabetes, it actually it meets the first criteria. The ketosis can be expressed in two ways: either a urine dipsticks where it should be 2+ ketones, or if you are measuring the serum ketones, it is more than 3 millimoles per liter. So if it is more than 3 millimoles per liter, ketosis is also present. Metabolic acidosis is defined as pH less than 7.3 or bicarb less than 18. So if these criteria are present, then you can diagnose it as DKA. The HHS diagnostic criteria is slightly different. Usually hyperglycemia, it is plasma glucose more than 600. See the difference, even a history of diabetes is enough in DKA, but in HHS, you need a sugar value more than 600. Hyperosmolarity, either measured or calculated osmolarity should be more than 300 or the measured one should be more than 320. Absence of significant ketonemia. So here again, you can see even if you have a urine ketone strip plus or beta hydroxy the serum ketones present, that does not exclude the diagnosis of HSS. Only thing, it should be 1 plus and the ketone should be less than 3. And absence of acidosis, like usually the bicarb should be more than 50. Again here, some bicarb somewhere around 18 is also not an exclusion of HHS. Okay. So that is how you diagnose HHS. So these are the diagnostic criteria for HHS, diabetes, and DKA. So now we will go to the next question. The following are causes of secondary diabetes except Down syndrome, Klinefelter's, Turner, Wolfram, and Edward. This is not pure critical care, but still you can have questions like that. So better go and read the theory aspect as well. So in Edward syndrome, it is not a cause for secondary diabetes. So you should be reading the causes of secondary diabetes, where you can have drug-induced, especially like as you are aware, the thiazide diuretic, loop diuretic, antihypertensive agents, then the protease inhibitors, especially like steroids and OCPs, glucagon, then again interferon, etc. Then sympathomimetic drugs can also produce, sympathomimetic drugs can also precipitate diabetes and other chemotherapeutic drugs. Then syndromes like Cushing syndrome, pheochromocytoma, acromegaly, hyperaldosteronism, Poem syndrome, etc. Then other genetic disorders like Down syndrome, Klinefelter's, Turner, Wolfram, the Friedreich's ataxia, Huntington's disease, etc. These syndromes can also be associated with secondary diabetes. Now, all the following statements are true about DKA, except all true except. So abdominal pain is common and may be accompanied by tender, guarded abdomen with absent bowel sounds. So you can have severe abdominal pain because of ketosis. It's a typical presentation. DKA patient vomit like guaiac positive coffee ground material. Postural hypotension is common, but a shock is rare in DKA. Then hypothermia in DKA is associated with sepsis. So, and pleuritic chest pain is not present. So, except pleuritic chest pain is not present is not true statement. You can even have a pleuritic chest pain sometimes in patients with DKA. So, you should read about the clinical manifestations. Like you can have, as we have already told, the loss of large quantities of fluid can have the dry skins, palpitation, postural hypotension, but symptomatic shock is usually rare. The patients with DK have the rapid breathing, or it's called as the Kussmaul's breathing. Then it has a sweet, fruity odor. Some patients with new onset DK have been misdiagnosed as having psychological hyperventilation. So hyperventilation is a very common feature here. DKA is not tachypneic. The physician should suspect that severe acidosis may be depressing the respiratory drive. So it is important to measure the temperature accurately because the patient is hyperventilating. Rectal or tympanic membrane should be measured. Patient with DKA do not have fever. Unless an intercurrent process, usually infection is present. So the same way, a patient with DKA and having a leukocytosis doesn't mean that the patient is having like infection. The same way you can see like abdominal pain is common and may be accompanied by tender guarded abdomen with diminished or bowel sounds. It is basically because of ketone bodies. The vomiters will be having these peculiar smell, and pleuritic chest pain may also be present. The cause is unknown, but it resolves with treatment with DKA. So that is also described. So that point you may not be very aware, but that pain, pleuritic pain is also possible. All the following statement about euglycemic decay are true except. So this euglycemic decay is also a favorite area. So you should have a clear-cut idea about what is euglycemic ketoacidosis. So patient with blood glucose below 180 milligram per deciliter and ketoacidosis. Then this is again the statements about decay are true except. So older age group patients with low GFR, then use of SGLT2 inhibitors can also lower plasma glucose at presentation in these patients. Dehydration is due to solute diuresis. Normal plasma glucose concentration is 3.3 to 6.7. So the answer is B. Old age group patients with low glomerular filtration. So that statement is not true. So normal plasma glucose concentration, as you are aware, 60 to 120. When it is converted into millimoles, it is 3.3 to 6.7. In rare situations, patients present with blood glucose below 180 milligram per deciliter and ketoacidosis, which we have already discussed, even the diagnostic criteria. This is described as euglycemic DKA. Younger patients with higher GFR are having, and use of SGLT2 inhibitors can also lower plasma glucose at presentation, and solute diuresis usually cause dehydration. So these are the points as far as euglycemic diabetic ketoacidosis is concerned. So all the following statement about diabetic ketoacidosis are true. All the following statement about DKA are true except. So which is false. So low sodium concentration may be due to osmotic effect of large amount of extracellular glucose. Hyperchloremic acidosis can also occur during recovery of DKA. Elevated serum phosphate concentrations are uncommon, and acidosis increases the beta hydroxybutyrate to acetoacetate ratio to 6.1. So which of the among the following statement all are true except. So it is C. Elevated serum phosphate concentrations are uncommon. So that is actually false. So low sodium concentration may be due to osmotic effect of large amount of extracellular glucose, which we have already told. Then hyperchloremic acidosis can also occur during the recovery of diabetic ketoacidosis. Then elevated serum phosphate concentrations are common with untreated diabetic ketoacidosis. The mechanism is not clear, but after the therapy, there is a precipitous decline to subnormal level. So initially, your phosphate level may be high, but with the treatment, like the potassium levels are lowering, the same way you can have a hypophosphatemia also during treatment. So otherwise, you can have an elevated serum phosphate concentration. So that is also a very important point, especially the MCQ part is concerned. And again, as I've already told you, in endocrinology part, you have to definitely read in detail about diabetic ketoacidosis, diabetes-related complications, then thyroid storm, then the adrenal insufficiency, then hypothyroid crisis. So these are the very important topic, along with the glycemic control in the ICU as well. So normal beta hydroxy butyrate to acetoacetate ratio is 3:1, but acidosis increases the ratio to 6:1 to even 12:1 as pH decreases. So that part also should be we should be aware. So how should a 73-year-old patient with severe acute pancreatitis during mechanical ventilation for 96 hours without hemodynamic instability be fed. So the feeding of a patient with acute pancreatitis, acute severe pancreatitis. So the parenteral feeding for at least 96 hours, then enteral nutrition according to tolerance. So this is a basic concept as far as enteral nutrition is concerned. Parenteral glucose and lipid emulsions are the enteral and enteral glutamine for initial hours, and then enteral nutrition according to tolerance. Parenteral feeding until extubation, no nutrition until day 7, enteral nutrition according to the tolerance. Very easy question. So I think you all will be aware. So in pancreatitis, early feeding is essential. And if the patient is tolerating, you can continue with the like oral or nasogastric feed itself. If the patient is not tolerating the nasogastric feed, then the like post-pyloric feed can be tried. Then only you can go with the like if that is also not tolerated, then we can go with the total parenteral nutrition. Or if the patient is not tolerating the enteral feed completely, then you can go for the partial parenteral nutrition. So that is the usual way you feed pancreatitis. And pancreatitis is also a very important topic. You have to read pancreatitis in detail. You can get multiple different types of questions from the pancreatitis area as well. So this is again, you are well aware, like patients with pancreatitis, enteral feeding should be initiated and it should be continued if the patient is tolerating that, and you don't have to auscultate for bowel sounds or don't have to keep the patient NPO. The seventh question, a 68-year-old man was admitted in the ICU after an elective CABG. His medical history includes COPD and hypercholesterolemia. His HbA1c is 5.8%, that means well under control. His ABG has, you can see here, his ABG has glucose of 150 milligram per deciliter. What do you do about glycemia? The select one. So I start insulin therapy already since I want to target strict normoglycemia. So the previously in critically ill patients and even in surgical patients, the strict normoglycemia was practiced. Nothing, I give insulin when glycemia is more than 210. I give insulin when glycemia is more than 180 according to the current guidelines. I give insulin when glycemia is more than 210, which is a renal threshold of glucosuria. Nothing, I only give insulin when glycemia is more than 180. So I start insulin therapy already since I want a strict normoglycemia. This was a slightly older concept. Now majority of the guidelines says that you don't have to go for a strict strict glycemic control even in surgical patients, even though there is a slight evidence previously. So this is the like as I've already told, the current guidelines. The current guidelines advocates glycemia between 110 to 180. So tolerating severe hypoglycemia has clearly been shown to be detrimental and should be avoided. That is a basic concept. But based on the available data, strict normoglycemia is still recommended, especially in surgical critically ill patients. This is based on the previous study. So this question is slightly old question. Concerning cardiac surgery patients also, the strict is the strict was practiced before, but again nowadays, as I've already told, we are worried about the complications because of hypoglycemia. So that is why the concept of strict normoglycemia is not practiced in the ICU, even though you have had evidence in postoperative patients before. True and false statement regarding critical illness myopathy, CIM. So previously it was called critical illness myopathy, but nowadays it is called as ICU AW, or otherwise called ICU acquired weakness. So the statements are it constitutes like spastic localized weakness involving limb muscles and neck flexors, including facial muscles and sparing diaphragm. Acute corticosteroid and pancuronium associated with myopathy and similar to CIM. There is no definitive evidence suggesting that neuromuscular blockers are the cause of these ICU acute weakness. Critical illness, polyneuropathy and myopathy appear to be important cause of increased mortality during and after acute care hospital stay. So here again you can see the initial this thing is wrong, but then second one, the corticosteroid and pancreonia, very easy statement. There is definitely evidence suggested that it can cause it is a neuromuscular blockers can cause more CAM. Then CIP and CIM appear to be important causes of increased mortality during and after acute acute care hospital stay. It actually increases the length of stay. So important cause of increased morbidity during acute care of hospital stay. So regarding critical illness myopathy, I think you all will be knowing that, as I've already told, it is nowadays called as ICU acute weakness. So all of the following statement about hyperglycemic hyperosmolar syndrome are true except which we have already discussed, more common in younger age group. Antipsychotic drugs clozapine and olanzapine can cause HHS. Fever is common finding during HHS even in the absence of infection. 33% of patients present with seizures. In HHS, blood glucose values may be as high as 2000 milligram per deciliter. So answer is A, more common in young age group. It is usually seen in older age groups. Antipsychotic drugs, clozapine and olanzapine can cause HHS. Fever is a common finding during HHS, even in the absence of infection. 33% of patients present with seizures and blood glucose values may be high. The diagnostic criteria itself is showing you need a glucose value more than 600, which we have already discussed. So fever is also a common finding during HHS. That point may not be very clear, but fever is possible as per the textbook statements. So mark the true and false statement for DKA and HHS. So begin fluid resuscitation of DKA and HHS before insulin therapy. So that is true. Low dose infusion of rapid acting insulin is recommended. The bolus doses are not recommended nowadays. Bicarbonate replacement is not recommended in managing DKA. So that is actually partially true because now some of the guidelines states that if you have a severe DKA and the acidosis is very severe and the patient is unstable, in that case you can have initial bicarbonate therapy. Phosphate replacement is not beneficial, no doubt about that. In patients with mild DKA, trial shows us subcutaneous injections for insulin every 1 to 2 hours to be as effective as intravenous infusion of regular insulin. So there are a few papers on that. More than subcutaneous, it is basically the IM insulins are recommended. Even there are previous recommendations, but especially when the patient's the peripheral circulation is impaired, the absorption may not be that good. Again, like a controversial statement, but theoretically speaking, that is true. So this is regarding the first 10 questions in endocrinology. The second one, which we have not discussed here, you have to specifically read about hyperthyroidism and thyrotoxic crisis. You can have multiple types of questions in thyrotoxic crisis, especially the diagnosis, the management. In management, different drugs and the action of different drugs in the hormone synthesis, release, etc. What are the drugs used? So that part is very important. And the beta blocker, which beta blocker to be used, and if the patient is hemodynamically unstable, whether we can use beta blocker. So those points are very important. The temperature management, etc. Hypothyroidism management is also very important, especially this mixed edema coma. So one important point you have to remember is you have to give steroid supplementation in that case. So that point should be very clear. And you have to read about other complications of hypothyroidism as well. Then the next part in endocrinology will be about the hypothalamo pituitary axis and the adrenal insufficiency. In ICU, how you diagnose an adrenal insufficiency, and in septic patients, giving steroid, the dose of steroid as per the latest sepsis guidelines also. Then the diagnostic criteria. Then obviously hyperaldosteronism, all those things. That is regarding adrenal part. So those are the major areas of endocrinology in ICU. Okay. So in this one, as we've already discussed, DK, HHS are very important, and you can get questions about insulin also. Nowadays, there are many types of analogs, basal bolus insulin regime, that is also getting extrapolated into ICU practice. So what are the analogs preparations? What are the short acting, long acting, the difference between regular insulin and the analog insulin? So those points should be very clear. Then you can just run through the oral anti-diabetic agents also. The best way to refer that will be, you have the latest ADA 2025 guidelines, and that they have given a chart in the treatment part about different oral anti-diabetic agents, the complications, which is producing weight gain, then in which all conditions which agent is preferred, the specific complications like the which one we have already discussed, euglycemic, the diabetic ketoacidosis, etc. Okay. So this is all about endocrinology. If time permits, we will have another sessions where we can have a detailed discussions, including other topics also.
Sir, do we get the explanation of these important topics like this, if you don't mind? Or just notes, sir. We can copy it from.
You want to you know
And sir, this important topic discussion, sir. If we get only the slides, we will read.
Okay, you are talking about the notes of
adrenaline and that hypothyroidism, thyrotoxics, adrenal insufficiency. These are the notes, and the slides are, so we can read over there.
Okay, I try to prepare and share with the academic people.
Okay, thank you, sir.
Any other help you need?
Thank you, sir.
Okay, thank you so much. And good
Thank you.
Okay, all the best.